How do you spot a charlatan online?
If they're not wearing clothes and they're in a supermarket, that's a fairly low-hanging fruit. Yeah. If they're topless and shouting at vegetables, it's a good place to start.
Alan Flanagan is an evidence-based nutritionist who's made it his mission to debunk misinformation online, including the truth about so-called dangerous seed oils.
For me, it's, I think, the best example of how inverted reality and evidence becomes online. They will take the entire converged body of human evidence and put it in the bin in favor of, but I found this rat study.
We discuss whether meal timing really matters, if personalized nutrition is more hype than health, and why everyone's suddenly frightened of carbohydrates and glucose spikes.
If you were to give me a choice between two risk factors and I have to have one of them for the next 10 years, and one was high LDL and one was, glucose intolerance, like I'll take the glucose intolerance.
And we explain the real world health damage these online health gurus are actually causing.
The idea that someone would forego clinical management of cancer in favor of a ketogenic, in favor of any diet, is actually quite terrifying, and I think people just need to be counseled in the strongest possible terms.
I'm Dr. Karan, an NHS surgeon, and in this podcast we cut through the BS of modern health advice and tackle the biggest issues in science, health, and medicine. What is happening in science and the field of nutrition right now? Misinformation sells so well, and the field is being fed by influencers cherry-picking evidence to reinforce their agendas. Some of these are people with actual qualifications in health and nutrition, not just unqualified quacks. So separating fact from fiction can get really tough. Dr. Alan Flanagan holds a master's and PhD in nutrition from the University of Surrey and is a major mythbuster in this space. In this episode, we discuss the promise versus reality of microbiome science, the rise of green supplement powders, diet tribes like keto and carnivore, seed oils, sweeteners, and more. Enjoy. Alan, thank you so much for coming on, man.
Thanks, Karan. Thanks for having me on.
No, I've been consuming a lot of content on Instagram since about 2018, and I went to university with Josh Warwick, right?
Okay.
And I followed his kind of journey, his weight loss journey back in 2017, 2018, whenever he was doing that. And I came across other people as well, things like James Smith, yourself, and I was following all these people online. And it's funny, back in those days, even though it wasn't too long ago, there wasn't such a mire of misinformation online. And there wasn't even that many creators online who educated in the way that you do. And now, in 2024, it seems you can't log on to Instagram or any social media platform without being inundated by self-proclaimed experts. And what's interesting is that for a while I thought this is only restricted to the online space, until I saw a patient a few years ago, and they'd come in with upper abdominal pain, and we got an ultrasound scan. They had gallstones. And I just looked into this patient's diet a bit more, and they were on a keto diet. And high-fat diets are a predisposing factor, or increases your risk of gallstone formation, certainly cholesterol stones. And I was told this patient that they should probably consider cutting back or go on a lower-fat diet to minimize their symptoms from gallstone attacks. Anyway, I saw them again a few weeks later, and this time I didn't see them in the clinic. I saw them as an emergency admission whilst I was on call with pancreatitis, gallstone-related pancreatitis. And what they had done is they had actually doubled down on their high-fat diet, because they'd also read online and seen videos that high-fat diets and drinking olive oil and such could help to flush out gallstones. And all this misinformation they'd got online had landed them in the hospital. So I was directly seeing the clinical negative effects of influencer information and having an impact on the NHS, on facilities, on actual patients in real life, which is worrying.
Yes, I am on the Heart UK advisory panel, and go to the Heart UK conference every year, where it's a clinical conference for the most part. We managed to squeeze in a little bit of nutrition related kind of material, and we decided last year we would do a series of case studies from some of the lipidologists, because it's frightening what they're seeing in clinic. And the two cases that we presented were both individuals following, in one case, just a kind of ketogenic, in another case, a fully carnivore style of diet. Diet-induced LDL had in one of those individuals gone to 21 millimole per liter. The other had an LDL of 14 millimole per liter. I mean, these are, homozygous familial hypercholesterolemia levels of cholesterol. I made the point afterwards discussing, just this kind of phenomenon with a few of the clinicians, that this is the part I don't see. Like, I work in research and I try to have this, kind of public facing science communication stuff, but I'm not a clinician. And so I really don't see the consequences of misinformation in the way that you or other, medical professionals or clinicians would. And so I really think that those stories are quite important. In fact, I was imploring the lipidologists to write these up as case studies, because we don't have, and we're probably not going to have, a randomized trial of a carnivore diet for its effects on cardiometabolic risk factors. We need contributions to the evidence, limited as they may be, in order for this to kind of propagate throughout, the kind of medical and healthcare disciplines, that this is not without consequence. And it's also frightening, I think, hearing, and I'm sure you've had this experience potentially with that patient example, of where these kind of individuals feel almost as entitled to speak to, a lipidologist with, 15 years experience, as if their knowledge is both equally valid. And it's this kind of my truth relativism that typifies a lot of, online dialogue anyway. And that's, I think, quite frightening, that there is this kind of concomitant with the rise of, the influencer, so to speak. There's also been a concomitant decrease in the value of expertise, and they are a combination that I think pose a recipe for disaster in the population. And I've no doubt that this information, whether it's, carnivore diets, their impacts on LDL, whether it's, the gallstones example you describe, whatever the kind of extremity of diet that people are taking, or other health practices as well. It's not restricted to diet alone, but it is going to add up in individuals to adverse outcomes. And that's the great tragedy of this, is that's almost inevitable. And yet we have, because of the nature of our information landscape now, essentially zero capacity to hold any accountability to sources of misinformation. So it's a really terrible time to be an evidence-based healthcare profession.
I wonder, I feel it's a combination of not only authority bias, someone has doctor in front of their name, or, loads of postnominals after their name, authority bias, but also combined with the fact that these pseudoscientists and misinformers are reaching millions of people off the back of maybe a problem that is emblematic of the healthcare right now, where people feel they're being failed by healthcare, or their chronic conditions have not improved despite countless clinic appointments and being shuttled back and forth between investigations and scans and consultations. And almost these online pariahs, these online messiahs, are their last bit of hope to turn around their chronic conditions. And they think, let me give it a go.
Yeah, I think kind of guruism, shall we call it that, is a very prominent characteristic of a lot of the kind of characters that we see online, and that we see propagating a lot of information. And of course, it's counter to everything about disciplines of academia, of science, of health science, or of research generally, that are grounded in the scientific method, and that are grounded in this kind of epistemic framework that is inherently oriented towards uncertainty and quantifying that uncertainty, and, error and margins of error. And all of this does not wash for people who are looking for certainty, and they are looking for the answer, capital T-A. And that is an environment that I think makes a lot of the kind of science communication side, and I've always been a little weird about that term for various reasons, but because I find there is no competition. There is no way that you can communicate this thing we call science with any sort of maintenance of the integrity in that research without communicating caveats and uncertainty. So you're never going to win against certainty and people that are seeking certainty and people that are looking to provide that certainty. Where I think it's important to make that distinction, though, and you raise a kind of important point within this, is, I guess, retaining a degree of the empathy for people who find themselves vulnerable to this information rather than the charlatans that are promoting it, for whom I have absolutely zero sympathy. But as an example, one of those case studies in the Heart UK conference last year that we presented was someone with severe IBS. They had done everything right. They'd gone through the NHS. They'd done the frontline, generalized healthy eating. That hadn't worked. They'd been filtered through a dietitian-led low FODMAP diet as a kind of second line intervention. That had no effect. They were very distressed by their IBS, and they went on a carnivore diet, and those unpleasant symptoms dissipated. Now, of course they would, because it represents really an extreme form of an elimination diet. If she had only eaten white rice as opposed to red meat, she likely would have had the exact same effects. But that was someone who I can have and extend a lot of empathy to, because they are struggling with a chronic condition for which we still have quite limited understanding relative to other conditions, and for which there is a huge non-responder rate in the available interventions that are recommended. So what do you do, and where do you go? And then, you find this kind of one catch all-encompassing kind of approach to your treatment. And I think a lot of people fall into that bracket. I can think as well of another area for where in nutrition there's a lot of poor information would be in relation to polycystic ovarian syndrome. So women with PCOS, there's a lot of different phenotypes that we now kind of understand. They seem to have various degrees of difference in their metabolic characteristics that might relate to diet, and yet we have huge gaps in our knowledge for how best to approach that. So of course people are going to look for alternate sources of information, and that is something where there are issues, and the research community itself obviously needs to kind of put its hand up in that respect. And women are hugely underrepresented in research, as just one example. So I think an important potential route from here is to kind of strip back some of the sense of ivory tower and epistemic arrogance that can come across with a lot of healthcare disciplines and medical science and health science and the research community, and kind of break that down in order that people aren't kind of persuaded to turn their back on it and to kind of go and find the messiah online.
I think, as you mentioned, although there are some cases where you can have negative effects of people listening to extreme diets online, as you highlighted, there's also examples in some cases where following these very extreme personalized nutrition profiles can be beneficial to specific cases that are completely refractory and treatment resistant to all other standard traditional treatments available on the NHS or any other health provider might provide. And an example which brings to mind is that of Jordan Peterson. Now, no matter what anyone thinks of his policies and his views on things, I think he's someone who, sticks to a steak a day or some sort of extreme meat-only diet. And even he says himself that no one else should do this. He clearly has some chronic gut conditions, which be bettered by limiting fibers and various other things. And that actually leads me to come on to a tangent on what we've been discussing, is personalized nutrition. This term has been manipulated and distorted to such a degree only to sell things to people, because I think there's a degree of personalized nutrition, which we've discussed. I mean, there might be some people with chronic gut conditions or IBS or various other things which might limit their intake of certain food groups. But again, for the average person, there is no real personalized nutrition beyond taste preferences. So why are these private companies offering microbiome testing, stool testing, genetic testing, food allergy testing, I mean, is there anything more to the science to all of that personalized screening for your food?
At this point, no. The personalized nutrition paradigm is not entirely new. The emergence of nutritional genetics and nutritional genomics, kind of 2010, 11, 12, 13, you can really start to see this become an area of potentially exciting promise in terms of the ability to understand that there may be categorical influences on an individual's response to diet that then require individualization. So a really good kind of low-hanging fruit example here would be people who have a certain genetic defect in a particular enzyme, the MTHFR enzyme, and that regulates folate, vitamin B9 metabolism. And there are some individuals who will have a genetic predisposition to that enzyme under functioning. And what essentially that means practically is they require more folic acid. They require supplemental folic acid because they're likely not going to get sufficient amounts of B9 through their diet in order to compensate for that. And so that's a well-known kind of example. And yet we know that there are some other, examples we could point to as well. But for the most part, they are isolated examples at this point in our knowledge. And fast forward 10 to, kind of 12 years, and there isn't necessarily much that we're further along down that line in terms of the extent to which we can take people's genotyping and personalized dietary recommendations according to it. So at this point, it's still confined to monogenic conditions that are identifiable, that have a specific effect on the metabolism of a specific nutrient. And in that context can be, a target for intervention accordingly. But what's evolved now over the past, say, 5 to 10 years is that concept of personalized nutrition has been taken to a approach where we can take all of this wider information. We can take genotype information. We can take information from stool samples in the microbiome. We can take individual responsiveness to, plasma glucose levels or continuous glucose monitoring, which is interstitial glucose. And we can take all of that information and put it together into a suite of dietary advice that is unique to this individual. And we have a number of landmark studies that have been conducted in this area, and they have returned the most underwhelming results for all of the sophistication of the intervention. In one study, for example, the addition of genotyping and phenotyping information on top of just personalized dietary advice that you could get one-on-one with a nutrition professional like a dietitian provided no additional value in the improvements in diet that were noted. That was the Food for Me study. We have other research that has kind of made a big deal out of the idea that we all have these inter-individual differences in glucose responses, and that, someone can eat a cookie but not a banana. The translation of that, I think, is reckless in the context of an average population intake in the UK, for example, that falls well short of the kind of intended, 5 a day. And the magnitude of the population improvements from focusing on achieving that target across the whole population in terms of its impact on burden of disease is far greater than this idea of one individual, specifying that they can eat this food and not that food from the data. And even at that, there are big issues with the kind of the validation of the metrics that are used in some of these trials, which are not what we typically use as standardized measures of glucose tolerance, for example, a 2-hour response to an oral glucose tolerance test. And again, even with all of that, the actual magnitude of difference between a personalized nutrition intervention group and, an algorithm-based, the kind of algorithm-based advice and a generic kind of control group is so paltry in its effect size that it's really not anything to write home about. So, yeah, this is a good example of that study conducted by a group in Israel, which, used all of this machine learning data based on like blood glucose tracking and microbiome and all this kind of stuff plugged into a nice big machine learning algorithm. And it came out with advice for, glycemic control. And that was compared to individuals getting one-to-one advice with a dietitian. And that one-to-one advice did just as well in terms of the blood glucose, management and glycemic control of these individuals as the machine learning algorithm. And because a lot of it is based around glucose monitoring, a lot of the algorithm just spits out generic recommendations for lower carbohydrate diets anyway. So I am entirely unenthused by the evidence for personalized nutrition from the major intervention trials that exist. I think the horse has unfortunately bolted from the stable in terms of the kind of hype around it, but I see it as science in service of a commercial agenda.
I mean, for me, CGM seems to be now the next step of healthy, normal people with normal functioning homeostasis claiming and pathologizing normal physiology and taking things from other conditions. Like, we've seen in the longevity space, people just taking metformin for the sake of it, which diabetics would probably not rather take. And again, most diabetics, if you speak to, they don't want to be continually monitoring their glucose, and it's a stressful thing to do. But again, normal healthy people monitoring their glucose, again, not understanding the difference between blood glucose and interstitial fluid, which is the glucose that's measured in these CGMs, but also anecdotally having spoken to some diabetologists, endocrinologists, and mainly cardiologists, I went to university with and who are now practicing, they've seen a massive uptick in deranged blood lipid profiles. And that correlates with people taking CGMs and people trying to, I guess, game the system and lower their blood glucose or their glucose response by eating higher, foods higher in fats to blunt that spike. And the ultimate effect of that, this kind of keto parallel diet, is to actually derange their blood lipids even more than just having a normal diet. And it doesn't seem to be getting through to people that for normal people, it has no effect whether your glucose spikes or not. But again, and I see people online, this comes back to these online space having a direct clinical impact. People like the glucose goddess who have really fearmongered and doubled down and pathologized the normal function to sell things. To sell harmful things which are unregulated, and who surprisingly have just made millions off of the back of something which is completely being outed by doctors, by scientists like yourself. But the machine just keeps marching on.
Yeah, it does. I find the CGM thing particularly bizarre, and I used CGMs and continue to use CGMs in some of our research, but in one study, for example, we had otherwise cardiometabolically healthy individuals. All I could see in that CGM data was noise. The fluctuations were of nothing you would be concerned about, nor interested in paying attention to. And of course, that was in the context of also having plasma glucose. We could actually see, we were feeding energy maintenance diets to participants so they didn't lose weight, so they weren't under eating, equally divided energy intake in 3 meals, 5 hours apart, and breakfast after an overnight fast. And your plasma glucose response was precisely what you would expect to see, as in there is this rise over this kind of initial period, and then by the 2-hour mark they're fine. It's returned to normal range, which is, again, what we expect to see. And those are the standardized measures that we have in terms of assessing glucose tolerance and insulin sensitivity, whether it's fasting plasma glucose or your 2-hour glucose tolerance, or, clinically, you would obviously do that with an oral glucose tolerance test. But even in response to mixed meals, we have very well characterized postprandial glucose dynamics and what they look like in otherwise healthy individuals. I cannot fathom for the life of me why people are trying to micromanage their postprandial glucose in this way. But like you said, the kind of trade-off now is so self-defeating, it's borderline absurd. You become so obsessed with micromanaging glucose responses that you end up, just kind of increasing your saturated fat content by 10, 12, 13, 14, 15%. And now your LDL's gone through the roof. And if you were to give me, I mean, this is an absurd dichotomy, but I want to highlight it because I find this so absurd. If you were to give me a choice between two risk factors and I have to have one of them for the next 10 years, and one was high LDL and one was, glucose intolerance, like I'll take the glucose intolerance. Like high LDL is the last thing I want as a risk factor in terms of a causal pathway to atherosclerosis. And they kind of fail to appreciate that although it's generally responsive to kind of changes in diet, it's often difficult to get really down with dietary change once you've maxed out some of the kind of low-hanging fruit in terms of dietary fat composition and fiber. My point being that, like, for blood glucose management and insulin sensitivity and glucose tolerance, that's actually relatively easy to manage in otherwise healthy individuals. Maintain a body weight and exercise, and that's kind of got you that box ticked. Whereas even for a lot of otherwise healthy, normal weight individuals whose diet is not bad, they may still require additional lipid lowering therapy at some point in their life. So it's wild to me that of all risk factors to become obsessed with, it's glucose tolerance rather than, dyslipidemia. But I think, there is this particular environment that we're in right now where more than anything, the kind of lipid hypothesis, the role of cholesterol and cardiovascular disease is probably one of the prime areas of online misinformation. So I'm kind of unsurprised as well every time I hear that someone has decided to adopt certain dietary practices nominally with the goal of improving their metabolic health, but doing so in a manner that is completely adverse to their long-term cardiovascular risk.
And I think that's really summed up by the fact that this weird dichotomy is that people will happily and readily eat more fat and kind of go into that keto diet, but at the same time, they'll vilify certain types of fats. And I'm not even talking about, the types of animal fat, but I'm talking about things like seed oils. And that seems to, pun not intended, be such an inflammatory thing online where people are really demonizing these things and link that with, like you said before, conspiratorial things, big pharma, the government, and all of that seems to be rolled up into one thing. And, seed oils, as far as some of the data suggests, may even be protective against cardiovascular incidents and events.
For me, it's actually I think the best example of how inverted reality and evidence becomes online. We have nearly 75, 80 years of really tightly controlled energy balance, metabolic ward studies, isolating the independent effects of different fats on blood cholesterol levels, robustly demonstrating that polyunsaturated fats of the type found in seed oils and linoleic acid, specifically omega-6, the one that's supposedly pro-inflammatory, have the most profound effect on lowering blood cholesterol levels in humans. And that's at the expense of saturated fat, i.e. the greatest magnitude of cholesterol lowering effect someone can get is where they replace the saturated fat in their diet with an equivalent amount of polyunsaturated fats. And we have multiple human intervention trials with hard cardiovascular endpoints, again, demonstrating that is not just a mechanism, theoretically, but related to hard cardiovascular outcomes in terms of coronary heart disease specifically, with risk reductions on average of about 30%, where you kind of reduce saturated fat from 15% and replace that with polyunsaturated fat and get that saturated fat down to, say, 8% of energy. So we've got tissue biomarker studies in epidemiology. So yes, they're observational, but you're directly measuring the concentrations of linoleic acid, for example, in either red blood cells or in adipose tissue or in, plasma phospholipids, whatever tissue compartment you measure the concentrations of linoleic acid in, they are all associated over the long term with lower risk of cardiovascular disease. And the reason that that's really reliable as a biomarker is because it's an essential fatty acid and we cannot produce it endogenously. So if it is present in the body, it is because it is consumed from an exogenous source, of which vegetable oils are the predominant source in most people's diet. And so you have this kind of coalescence of evidence from metabolic ward studies, hard outcome human intervention trials, biomarker studies, other just general dietary assessment based epidemiology, every line of evidence except for rodents, right? And so, yeah, you can isolate omega-6 and feed it in supraphysiological amounts to a rat and you might see some adverse effects. And they will take the entire converged body of human evidence and put it in the bin in favor of, but I found this rat study. Or there are some poorly controlled and confounded human interventions from the late 60s and 70s that, purported to find an adverse effect of kind of omega-6 linoleic acid vegetable oil rich feeds. They will take that single isolated study, which we're able to explain, we're able to reconcile those findings against the totality of evidence and say, nah, I don't believe any of that. Here's my one rodent study and here's another random human study from 1967. And so this is the nature of this kind of environment that we're discussing, this ecosystem of information that is fundamentally so distorted that you can take a body of evidence that is as kind of good as it gets for a human nutrition intervention, a recommendation you would give to someone at risk of cardiovascular disease with high lipids who needs to manage and reduce their risk factors through diet. This is the lowest hanging fruit you would be telling them as a dietary change. And yet in the online world, that has completely been inverted. And like you said, it comes with this kind of anti-authority, anti-governmental kind of conspiratorial narrative that makes it quite potent for people.
Whenever I was doing research on surgical outcomes or, for example, the last meta-analysis I published was something on pancreatic cancer and the treatment outcomes for certain types of pancreatic cancer. If I included any rodent studies in that meta-analysis, it would get rejected by any surgical journal I presented it to, or even my boss would not allow me to publish that research or put his name on it. And it seems bizarre that people would actually extrapolate rodent studies, mice models, animal models, and base the evidence from that, the outcomes from that to humans. And I guess this is nicely epitomized by, the kind of the artificial sweetener world, the non-nutritive sweetener world, where even the WHO, unfortunately, has suffered a communication error in this regard. And the whole world seems to be against artificial sweeteners, and primarily based on studies done on mice, which were given several thousand times a physiological dose that is safe for a human, and then showed some mechanistic evidence in that, like, hey, look, if we give several 100,000 times the acceptable dose to mice, ergo, it's bad for humans to consume one Coke Zero, which just sings to me the problems in nutritional science, not just nutritional science, but also in the people trying to interpret those studies and cherry picking data to suit their own nefarious goals.
Yeah, so this is a really good example because within the research world, all researchers, no matter kind of what area they're in, will understand that there is a place for different types of evidence, right? Some people do, primarily cell culture based, models in their research. There is a place for that. Some people focus on human clinical interventions. There is obviously a place for that. Some people focus on epidemiology. We need that too. So what always struck me about the artificial sweeteners thing was it's a great example of a complete breakdown in that understanding. And that relates to the animal models that people typically come out and say, oh my God, look, these rats developed, cancerous tumors over X amount of time. But what they're typically taking are toxicology studies. These are studies whose actual purpose is to investigate and push thresholds of an exposure that is going to be added to the food supply as high as they can, because it's based on whatever adverse effects are observed at a certain dose, that we ultimately end up with recommendations for their allowed amount in the food supply. So this research is really important for additives to the food supply, whether they're a non-nutritive sweetener or another kind of a coloring, for example, because these are not obviously vitamins, minerals, or otherwise. So if they're going to be added to the food supply, there is going to be an exposure in the population to whatever this additive is. And we need to know what levels are going to be permissible that may relate to risk. And so what's hilarious is when hysteria comes from these types of studies, not realizing that A, their purpose is to try and elicit these types of responses, but B, the process of then taking whatever dose adverse effects were noted at and working backwards to permit a certain amount, a tolerable upper level of an exposure in humans, is so conservative that the net result of what you're allowed and ultimately what people consume is orders of magnitude lower than anything, that was ever even close to a dose at which an adverse effect was observed in research. So, it's typically like 1/100th is the kind of minimum, no observed or lowest no observed adverse effect level. And then from that, you get these recommended allowances for the food supply and for human consumption. So it's a real example of the failure. And I guess in many respects, this is deliberate by people who, will have an agenda, the deliberate misrepresentation of the purpose of certain types of research, and then the findings from that divorced from the context of that purpose. And I think the recent example with, and yet you were right, the World Health Organization, that was a blunder really in their kind of science communication. They did come back, if I recall, and attempt to rectify that. And that related to their kind of conflation of the concept of a hazard relative to the actual exposure level. And look, that's an issue that I think we could, go down a complete rabbit hole in, because I think science communication, this is why I don't like that term. It's easy to do badly. And I think it was probably done badly during COVID, for example. I think there's a lot of areas where we've realized the limits, the pitfalls, and the challenges over the last 5 years in particular of trying to take this complex, uncertain subject and explain it in a way to the public that it's kind of understandable. And the WHO confusion about artificial sweeteners over the concept of risk, which is where they kind of goofed up, was a really good example of that. And yet, even now we have individuals, like you said earlier, the authority bias component, people who are often credentialed scientists on social media discussing poor studies. There's been a couple of observational studies that came out of a cohort in France that suggested a higher risk. They are massively limited studies for various reasons. And then animal toxicology studies completely taken out of their context. And yet they are communicating that to the public as if there is a cause for concern with artificial sweeteners. And it's completely negligent, I think, to do so based on this evidence.
I think one of the biggest distortions of science, just kind of going in on that, when I came onto the online space from consuming content to creating content, was about cancer and the cancer misinformation about sugar feeds cancer. And I always wondered, why is that link being made? And I went into a bit of a deep dive and kind of dredged up my old medical school slides on the Krebs cycle and things like that, and kind of rehashed some of the learnings that I made as a second-year medical student. And it seems so silly, but I can see how people believe it. One glucose molecule produces 32 molecules of ATP, adenosine triphosphate, the energy of the cell, and it's broken down into 3 stages. Stage 1 produces 2 ATP, stage 2 produces 2 ATP, stage 3 produces 28 ATP. but cancer cells can only basically do stage 1 and produce 2 molecules of ATP. So more sugar means that cancer cells can work more efficiently and are happy. So ergo, more sugar equals happier cancer cells, they grow more. But that also means that if you completely get rid of sugar, all the other cells go to shit as well, including the cancer cells. So I can see how from a small grain of truth, it becomes this distorted, mutated message where it's like sugar causes cancer, sugar drives cancer. And then you go into this whole world of let's go natural, let's go food, let's eat whole foods, unprocessed. And this takes me back to how, potentially this was a causative factor in Steve Jobs sadly passing away, where he had a curable, treatable type of pancreatic neuroendocrine tumor, which was surgically resectable. He declined surgery at that time and instead went on a kind of a fruitarian juice diet.
Oh, God.
And in that point, his cancer metastasized to his lungs, to his liver. And then he wanted surgery when he realized the fruitarian diet wasn't working. But at that point, it was inoperable because of the widespread metastasis. And that is one example of how a lot of people sidestep traditional thinking and medicine and go into this kind of holistic, whole food, naturalistic world.
Yeah, I came across a study, I think it was probably within the last 5 years, it's definitely a few years ago, that looked at cancer outcomes relative to, treatment option between people who would go for whatever recommended treatment is for that particular cancer site, or opt for alternative treatments, be it diet or whatever. And, without being too dramatic, the basic conclusion was if you opt for alternate treatment, you die, and forego, the treatments that are available. With the ketogenic diet, I mean, this is a real example, I think, of, you mentioned that concept of a grain of truth. The ketogenic diet is a very fascinating diet from a nutrition and metabolism perspective. From a research perspective, it's pretty fascinating. It's not new. It's popular, widespread kind of ubiquity is certainly new, but the diet itself dates to the 1920s, when it was kind of developed in pediatric drug refractory epilepsy, for which it's still an effective intervention. It's a fascinating diet that even 100 years later, we still don't really have that great an understanding as to why it has some of these potential properties, at least as it relates to the central nervous system. Now, cancer obviously then has been a kind of an interesting focus of the diet as well, largely related to this kind of specious assumption related to the Warburg effect that, right, if we just kind of attenuate, we can give cells an alternate fuel source that doesn't actually feed malignant growth, so to speak. There's some fascinating work in animals. There's been some very minor kind of pilot interventions in humans. There is nothing there yet that would even suggest that we could be recommending this in any clinical context. That said, there is the potential for some interesting work to still be further done in that area. It may not relate to nutritional ketosis per se. There's another emerging paradigm that relates to kind of intermittent energy restriction, but this is in the context of individuals undergoing conventional treatment, chemotherapy. This is intended as an adjuvant to that therapy. But at this point, we are really still in very early stages of kind of validating this in human interventions. And so the idea that someone would forego their clinical management of cancer in favor of in favor of any diet is actually quite terrifying. And I think people just need to be counseled in the strongest possible terms that that's a disastrous road to take.
One nutritional idea which has, I think, got the world fascinated is about chrononutrition and the timing of food. And as someone who deals with guts on a regular basis, I see some link between, I understand that there is evidence and I see it, that our gut motility, our gastric motility, the peristaltic motions, the secretion of hormones and juices and digestive enzymes all decrease and attenuate as the day wears on. They have their peak in the late morning, and then as we approach bedtime, they follow the circadian pattern of our metabolic function and our temperature, etc., and they all decline. Now, this chrononutrition, how much can we read into it in terms of how much we can benefit from timing our meals, timing our medication, and in terms of metabolism, fat storage, fat deposition, and how much timing of food can affect all of those things? How much credence can we put to these claims about the benefits of chrononutrition?
Yeah, it depends essentially. At this point in the evidence, it kind of depends on the outcome. I think we can, at this point, fairly concretely conclude that as it relates to weight loss specifically, there really is no advantage to various forms of timed eating or intermittent energy restriction, whether that's intermittent fasting or time-restricted eating, compared to just continuous energy restriction at the same level of energy. So fundamentally, the kind of equalizer there is the actual magnitude of energy restriction, and there's no greater weight loss or advantage to any sort of timed kind of strategy in that regard. Where we're still uncovering, and in the early stages of kind of uncovering, but the quality of the research in this area tends to be quite good in terms of quite robustly controlled human inpatient laboratory studies, often conducted in energy balance to avoid the kind of confounding effects of differences in energy intake. Where this field is looking at potentially contributing something of real substance, I think, is in relation to kind of time of day variation in glycemic control and in glucose tolerance. And that relates to kind of pre-diabetes management, potentially diabetes management. And this is because that kind of time of day effect that you describe very robustly relates also to diurnal rhythms in glucose tolerance, which are kind of amplified in the early part of the day in response to kind of early energy intake and very diminished in the later part of the day, even comparing the same kind of energy and macronutrient content to a meal. There is a growing understanding in humans that potentially meal timing can help to actually synchronize circadian rhythms in peripheral tissues. So there could be importance there for shift workers or people who are looking to reorientate, resynchronize to a new environment after jet lag. I think for kind of human interventions at this point, there still needs to be some more confirmation that that glycemic effect of temporal distribution of energy is of a sufficient magnitude that actually justifies it as a recommendation. The mechanism is certainly there. The evidence in kind of laboratory-based studies is there, but there isn't really kind of, more free living human intervention trials over a kind of longer term period. There are some, but they tend to be kind of smaller studies. So I think that is an area that holds a lot of promise, I think, in terms of overall diabetes management. But in terms of people looking for some magic pill for weight loss, there's really no additional benefit to kind of any sort of timed eating regimen compared to just continuous linear energy restriction.
I think, that speaks to one form of growing science, which could be interesting. And another I see as a parallel to that is this whole space on the microbiome. And at the moment, it seems that it's a lot more hype than health. And I certainly have a lot of hope myself for the promise of clinically translatable research that we will get from microbiome research in the future. And that includes potentially personalized nutrition. And at the moment, I see interesting things like fecal microbiome transplants, which have shown clinical positive effects for various inflammatory bowel disorders, Clostridium difficile infections, and potentially in the future, other autoimmune conditions as well. And even, I speak to a lot of oncologists who are appreciative of manipulating the microbiome potentially in the future to help with cancer therapies like immunotherapy as well. These are all interesting things that, changing and manipulating the microbiome could do. But I feel that this microbiome world has opened a door for people to come in and be like, oh, it's so important that you should eat our supplement. And that includes all these green powders, various green powder companies that have cropped up over the last few years, just throwing in the microbiome as like an added cherry on top. Like, yeah, this has probiotics. This can improve your gut, brain, etc. And that's not even including the countless number of influencers I've seen now, not only in the nutrition space, but the fitness space and beyond, who are massive proponents of probiotic supplements. Why is there such a hype, and does the evidence stack up at all?
I don't think so personally. I think the hype is explained similarly to what explains the hype around personalized nutrition, which it has the veneer of sophistication, the veneer of being sciencey. But in terms of what we know, I mean, we're scratching the surface of an ecosystem, an entire ecosystem, for which we have fairly tenuous. We have the broadest conclusions, the broadest possible associations of a certain composition apparently seems to correlate with kind of good health. But there's chicken and egg issues within that, as well as whether it's kind of causative of that health or a reflection of that health, so to speak. And similarly then with disease states, I think a huge caveat for me was two really elegant studies published last year, where basically our entire basis of the inferences we've been making in relation to the microbiota, its composition, and the kind of microbiome generally, has been based on stool samples. And from stool samples, whatever the composition of bacteria is, or secondary bile acids, or other kind of relevant exposures that are in there, we have been kind of drawing these pretty broad conclusions about the entire gastrointestinal system. And these two studies used a capsule-based technology designed to open in a certain pH environment of the stomach or the small intestine, or two areas of the large bowel, 4 different sites throughout the gastrointestinal system. And essentially what they showed was that the composition of all of these factors, bile acids, secondary metabolites, the microbiota itself, differed in all of these regions. So essentially, stool doesn't appear to actually provide us with this window into the entire GI system that we thought. And I think that really should temper our position on what we think we know with the microbiome. For me, I think we know nothing, essentially, in a scientific sense. I think we really do not know anything of substance at this point. I do think, and I do agree with you, it is exciting. There's the potential for new technological advances to allow us to further that knowledge. It's clear that there is this entire ecosystem kind of residing within us, and indeed on our skin and all this kind of stuff. To what degree it's a target for deliberate manipulation to improve host health, I don't know. I don't think we have evidence at this point that supports probiotic use, especially in otherwise healthy individuals. Potentially some benefit in individuals with IBS, very hit and miss. Most of the evidence for benefits of probiotics are in different diarrhea conditions. But for the most part, I just don't think there's any sense to probiotic supplementation in otherwise healthy individuals. And at this point, based on that recent research, I kind of am very disinclined to make any sort of assumptions about what we know about the microbiota, in both its general role in health and as a specific target for intervention or treatment at this point.
If you were advising someone who was consuming, who wanted to learn more about health, nutrition, and science in general, about medical matters, and they were going online, what are some red flags you would want to point out in terms of someone watching their content and thinking, hang on, this is a red flag, this could be bullshit, this could be pseudoscience, this could be wildly exaggerated claims, and just to be careful of that?
If they're not wearing clothes and they're in a supermarket, that's a fairly low-hanging fruit. Yeah. If they're topless and shouting at vegetables, it's a good place to start. But in terms of more subtle things, I genuinely now, I would say if they are offering advice that appears to contradict some just basic known knowns, right? That is counter to kind of general public health advice or seems to be contrary to a status quo, then I would really take it with a pinch of salt. You know, if someone says artificial sweeteners are really dangerous for our health, listen, we have entire regulatory systems set up to validate and approve their safety and use in humans, in populations. If there is a negative effect, it is the biggest failing of multiple layers of this. So, you know, that would be something that to me would be like, okay, this seems contrary to the fact that these are generally kind of considered safe to use. Maybe I'll treat this information with a grain of salt. You know, if it's contrary to our just basic dietary guidelines, I would treat that with a grain of salt. If they tend to speak in absolutes as well, rather than caveats of certainty and uncertainty, I think that would also be a real amber light for me. And for nutrition, I think if they're presenting things as very kind of dichotomous, this is good, this is bad, which doesn't really exist for foods and human nutrition. It's typically related to a range of exposure from kind of low intake to high or excess intake. So there's generally no kind of absolutes in that regard. Then I think if they're speaking in those kind of absolutist, dichotomized, black, white, good, bad terms, that's also a pretty good indication that it's an amber light for what's coming next.
Brilliant. I mean, hopefully someone listening to this can actually get some much needed nuance into this murky world of misinformation, particularly when it comes to nutrition as well. So, Alan, just want to thank you very much for spending your time and knowledge as well, and hopefully providing someone with a basis to have a bit more grounding when they're looking at stuff online, but also applying some of the things we talked about to their daily lives. Thank you very much.
Thanks, Karan. It's been a pleasure.
Thanks again to Dr. Alan Flanagan. Next episode, we meet neuroscientist Camilla Nord, who tells us what's really going on in our brains when we experience anxiety and depression. She also shares the latest science on how to improve our mental health, which includes eating chocolate. Subscribe so you don't miss that and the weekly Dr. Karan Explores podcast. Otherwise, I will see you sweet chocolate munchers next week.